Archana is joining our meeting from the airport.
Yeah, live,
Yes,
please.
yes, yes.
Okay. Uh, I welcome you all to the I welcome you all to the Journal Club session 5 and yet another interesting topic today. And we have a very renowned and esteemed faculty today. And without further ado, I would ask the MOS president to give an opening word.
Thank you, Dr. Vaishal.
Yeah.
Thank you. And welcome one and all to this lovely session of Journal Club. And I appreciate the efforts of the entire BOA team for putting together this lovely session. And welcome to everybody. And let's get into the session as early as possible.
Yeah.
All the best.
Yeah. Thank you. Can I have Dr. Omkar say a
Hi,
few words?
Vaishal.
Hi.
Hi, everyone. I hope this journal club is as enriching. Today's topic is as enriching as the last time. And I think Archana will be able to guide us how to take about along with Sabyasachi as well as Vaishal yourself and our team of esteemed colleagues.
Fine. So with now I ask Dr. Zain Khatib to introduce our faculty for today. Dr. Zain.
Thank you, Vaishal sir, Anaga Madam Omkar sir, for opening this meeting. So we have a very, very interesting topic today. I think very relevant to all general ophthalmologists also. A new drug which is being prescribed, and we ophthalmologists are getting a lot of reference on this drug called Monjaro. So we have a very, very esteemed faculty to guide us about this specific topic and to dissect this specific article that we have chosen for this journal club. So, in our panelists, in the national faculty, we have none other than Professor Dr. Dhanashree Ratra, Madam. She's a very, very renowned vitreoretina surgeon with more than 30 years of experience. She's a beloved teacher at Sankar Netralaya. She's the Deputy Director of Vitreoretina Services there. She has over 138 peer-reviewed publications, more than 18 book chapters, and more than 300 invited lectures, including 6 keynote addresses in international conferences. Welcome, Madam. Thank you for joining us. Our next national faculty is Dr. Debdulal Chakrabarti, again, very, very renowned senior vitreoretina consultant at Disha Eye Hospital. He's currently the in charge of VR services over there. He too has more than 22 years of experience in the field of VR surgery, has presented over 500 papers and lectures at many international national conferences, more than 80 peer-reviewed publications. He is a very active researcher and is currently principal investigator in multiple clinical trials, also a reviewer and advisory board member for multiple journals. Welcome, sir. Thank you so much for taking your time out for joining us in this meeting. And our state faculty is none other than very own Dr. Nishikant Borse, sir, who is from Mumbai. He has been, one of the senior practicing vitreoretina surgeons since last 25 years. He is the director of Insight Eye Clinic at Dadar, Mumbai. He is specifically known for, his innovative approaches in the field of retina surgery and has won multiple awards at national, international conferences, notably some of them being the Red Buckler Award by the American Society of Retina Specialists, and the Cesare Forlini Award by European Vitreoretina Society, CS Reshmi Award by AIOS as well. Sir also has several publications and presentations at national and international conferences and more than 10,000 surgeries to his credit. Welcome, sir. Thank you for joining us. And for the dynamic team of who are going to be presenting and moderating with me, the presenter, we have Dr. Tanvi Karande. She is a junior resident Department of Ophthalmology at the Government Medical College and Hospital, Chhatrapati Sambhaji Nagar, Aurangabad. And to co-moderate the session with me will be Dr. Sangeeta Sisode, Madam, who is Associate Professor, Department of Ophthalmology, GMCH, Chhatrapati Sambhaji Nagar. Welcome, madam. And to mentor the session is Dr. Archana Vare, madam, very senior professor and head Department of Ophthalmology, GMCH, Chhatrapati Sambhajinagar. Welcome, madam, and thank you so much for agreeing to take over this journal. And without wasting much time, let us go ahead and start with the presentation. So I request Dr. Tanvi to please share your screen and start the presentation on this topic.
Yes, sir.
Dr. Tanvi, I, Dr. Tanvi, you're on mute.
Is my screen visible, sir?
Yes,
Yeah,
it's
yeah, yeah.
visible. Yeah. Please go ahead.
Good evening, everyone. I am Dr. Tanvi Prasad Karande, a second-year junior resident in Department of Ophthalmology at Government Medical College Chhatrapati Sambhajinagar. I would like to sincerely thank the Maharashtra Ophthalmological Society and the Bombay Ophthalmologists Association for giving me the opportunity to present on this platform. I will be presenting an article under the guidance of Dr. Archana Vare ma'am, who is professor and head of department, and Dr. Sangeeta Patil ma'am, who is associate professor in Department of Ophthalmology of GMCS Chhatrapati Sambhajinagar. I will be presenting an article on early worsening of diabetic retinopathy in individuals with type 2 diabetes treated with tirzepatide, a real-world cohort study. It is an original article by Adam J. Buckley et al., which was published in Diabetologia Journal on 10th of July of 2025. Rapid tightening of glycemic control can lead to a paradoxical early worsening of diabetic retinopathy. It is reported in people with type 1 diabetes undergoing intensive glucose lowering as a part of diabetes control and complications trial, and has also been described in people with type 2 diabetes in small case control studies. Early worsening of diabetic retinopathy is observed with intensive insulin therapy and glucagon-like peptide 1 receptor agonist like semaglutide. Tirzepatide is a novel GLP-1 receptor agonist and gastric inhibitory polypeptide coagonist licensed for the treatment of type 2 diabetes. It has a potent glucose-lowering effect, potentially increasing early worsening of diabetic retinopathy risk relative to less effective therapies. Despite this potential, intensive glucose-lowering therapy results in lower rates of retinopathy and better long-term eye outcomes. The aim of the study was to investigate whether initiation of tirzepatide treatment was associated with early worsening of diabetic retinopathy in a real-world clinical setting. It was a real-world retrospective cohort study where 1:1 of propensity score matching was done. It was done using electronic medical record data from the diabetic retinopathy screening program. The patients with type 2 diabetes mellitus, where gradable retinal images could be obtained for evaluation for before and after of tirzepatide treatment initiation, were considered for the study. The patients with prior proliferative diabetic retinopathy, recent anti-VEGF therapy, patients with diabetes of other than type 2 diabetes were excluded from the study. The Imperial College of London Diabetes Centre had a dedicated in-house diabetic retinopathy screening program in which two 45-degree fundus photographs were obtained annually using mydriatic digital photography for all the patients with diabetes which were included in the study. The study was conducted from 24th October 2022 when tirzepatide became available at ICLDC to 9th of August of 2024. The follow-up was censored at 550 days after tirzepatide initiation. Data was collected from electronic medical records. Retinal images were graded using English National Health Service Diabetic Eye Screening Program form and later were compared with early treatment of diabetic retinopathy study and international classification for diabetic retinopathy for retinopathy and maculopathy in electronic supplementary material. Several inclusion and exclusion criteria were applied in the study. The inclusion criteria were consisted of adults aged 18 years or older, patients with confirmed diagnosis of type 2 diabetes mellitus, patients who had at least one gradable diabetic retinopathy screening exam within 24 months preceding 24th October 2022, patients who underwent at least one retinal screening exam after 24th October 2022, patients with gradable retinal images available for analysis, patients with documented exposure to tirzepatide defined as at least 2 dispensing records and approximately 180 days of treatment. The exclusion criteria was composed of patients with diabetes other than type 2 diabetes mellitus, patients with ungradable or unavailable retinal images, patients who had history of proliferative diabetic retinopathy, patients who had received intravitreal anti-VEGF therapy within 60 days prior to initiation of tirzepatide treatment. The study included a total population of 6,869 participants, comprising of 3,435 or tirzepatide exposed group and 3,434 of matched controls in the tirzepatide unexposed group. A 1:1 of propensity score matching design was used to create comparable cohorts. Electronic medical records from the Imperial College of London Diabetes Centre was the main source of data, which was conducted from October 24, 2022, when tirzepatide was launched at Imperial College of London Diabetes Centre and concluded on August of 9th of 2024. Further, inclusion and exclusion criteria were applied. Retinal grading system was done using English National Health Service Diabetic Eye Screening Program form. They were assigned a retinopathy R and a maculopathy M grade per eye. Submatching was done, wherein mild NPDR and R1M0 was split into R1A, where only one eye is affected, and R1B, where both eyes were affected for precise matching. They were further matched with 1:1 of propensity score matching design. The baseline characteristics of the matched participants were comparable between tirzepatide treated group and the matched control group. Several variables were considered and they were included, such as gender, duration of diabetes, average HbA1c levels, bariatric surgery status, baseline retinopathy or maculopathy eye grades, LDL cholesterol, mean arterial pressure, triglycerides, weight, body mass index, whether the patient had any concurrent drug uses such as insulin, sulfonylurea, SGLT2 inhibitor, DPP4 inhibitor, GLP-1 receptor agonist, fenofibrate use, or whether the patient had any pre-existing microalbuminuria. The above table shows association between tirzepatide exposure and new onset of proliferative diabetic retinopathy. Tirzepatide exposure was associated with a more than twofold increase in the odds of developing proliferative diabetic retinopathy, with an odds ratio of 2.15 at 95% of confidence interval and a p-value of less than 0.01. In contrast, post-initiation HbA1c levels, LDL cholesterol levels, mean arterial pressure were not significantly associated with the outcome. The above table shows incidence of new moderate to severe NPDR or PDR in individuals with R1MO or R1M1 at baseline. Tirzepatide exposure on these patients gave an odds ratio of 1.294 with p-value of 0.175, making no significant correlation between them. This table shows an association between tirzepatide exposure and incidence of new retinopathy of any grade in individuals with no retinopathy, that is R0M0, at baseline. A Z-score of -3.792 is obtained with an odds ratio of 0.733 and a p-value of less than 0.001, making it a rather protective factor in the patients with no retinopathy at baseline. The above table shows an association between tirzepatide exposure and incidence of new maculopathy R1M1, R2M or R3M1 in individuals without maculopathy at baseline. An odds ratio of 1.017 was obtained with a p-value of 0.873, proving no significant association between them. The use of tirzepatide in individuals with type 2 diabetes presents a complex relationship with diabetic retinopathy, characterized by both increased risks for high-risk patients and protective effects for those without pre-existing disease. Increased risk of PDR. Tirzepatide exposure for at least 180 days was significantly associated with increased odds of new onset PDR. High-risk groups, the risk was most pronounced in individuals who already had moderate to severe NPDR or mild NPDR with maculopathy. In this study, 1.1% of tirzepatide-exposed individuals developed proliferative diabetic retinopathy compared to 0.5% in the unexposed group. Protective effect. Conversely, for the individuals with no retinopathy at baseline, tirzepatide appears to reduce the risk of developing any new retinopathy. Mild NPDR. For those with mild NPDR without maculopathy, the study found no significant association with disease progression. The SURPASS clinical trials did not initially report an increase in early worsening of diabetic retinopathy with tirzepatide, where those trials often excluded high-risk individuals with severe pre-existing retinopathy. In the SUSTAIN 6 study, found that the semaglutide exposure and the degree of reduction of HbA1c at week 16 were independently associated with increased risk of new diabetic retinopathy. The LEADER trial, where liraglutide exposure was not associated with a significant increase in retinopathy hazard. A potentially important distinction between all these trials is the mean reduction in HbA1c level. Increased risk of proliferative diabetic retinopathy. Tirzepatide therapy was associated with significantly increased odds of incident PDR, particularly in individuals who already had moderate to severe NPDR or maculopathy. Neutral impact on mild NPDR. In patients with mild NPDR without maculopathy, tirzepatide was not significantly associated with retinopathy progression. Protective effect for low-risk patients. Conversely, the treatment appeared to reduce the odds of new onset retinopathy in individuals who had no diabetic retinopathy, that is R0M0, at the start of the study. Clinical implications. Specialist referral. Because of the increased odds of progression to PDR, specialist ophthalmologist referral is justified for patients with moderate to severe NPDR who are starting tirzepatide treatment. Targeted monitoring. The findings suggest that while intensive monitoring is necessary for high-risk patients, it may not be required for those with no or very mild NPDR, providing reassurance for the majority of users. Baseline status. The severity of pre-existing retinopathy is a primary risk factor for early worsening of diabetic retinopathy when initiating potent glucose-lowering agents like tirzepatide. The strength of the study was being a large population-based study wherein proper matching of participants and comprehensive retinal screening was done. The study included high-risk individuals and was a real-world external valid study where frequent clinical monitoring was done. The weakness of the study were as follows. It was a retrospective cohort study which is subjected to inherent observational bias. It had patients with relatively well-optimized glycemic control. It also had several statistical and data limitations. For example, socioeconomic information wasn't considered in the study. It also had selection bias, wherein the participants had a relatively long mean diabetes duration. MARI analysis, where methods, assignment, assessment, results, and interpretation and extrapolation will be discussed. Methods. It is a retrospective real-world cohort study, wherein the study hypothesis and population is well defined. A sample size of 3,435 or tirzepatide exposed individuals and 3,434 of match controls with 1:1 of propensity score matching was considered in a study period of 550 days. Matching process. Researchers used 1:1 of propensity score matching design to create comparable groups. The groups included an exposed group of 3,435 individuals dispensed tirzepatide for at least 180 days, an unexposed group of 3,434 individuals matched for gender, diabetes duration, baseline retinopathy status, HbA1c levels, and use of other glucose-lowering medications. Comparison. This matching aimed to ensure that differences in the outcomes could be more clearly attributed to tirzepatide rather than baseline clinical differences. Assessment. Primary endpoints. The study looked for incident proliferative diabetic retinopathy, retinopathy progression, incident maculopathy, and new onset retinopathy. Measurement tools. Outcomes were assessed using annual digital fundus photography, wherein 245-degree images were taken. Quality control. Images were examined by two licensed retinal graders and were reviewed by a consultant ophthalmologist, providing a more objective measure than the event reporting used in the previous trials. Results. Patients on tirzepatide had more than double the odds of developing proliferative diabetic retinopathy. No significant progression was seen in individuals with mild NPDR. Reduced risk of new retinopathy in healthy eyes among participants without baseline retinopathy. No increased maculopathy risk. Maculopathy incidence was similar in both the groups and no significant association was found between them. Interpretation. Baseline risk is crucial. The authors conclude that the risk of early worsening of diabetic retinopathy with tirzepatide is highly dependent on pre-existing eye disease. Clinical recommendation. The increased risk for high-risk patients, those with moderate to severe NPDR or maculopathy, justifies specialist ophthalmologist referral and targeted retinal photography when starting the treatment. The study provides reassurance that the early worsening of diabetic retinopathy is a rare in patients with low pretreatment risk. Extrapolation. The strengths of the study were the use of real-world data and a large, well-screened population enhances the study's external validity compared to highly controlled clinical trials. The limitations include a selection bias, wherein most participants were switching from GLP-1 receptor agonist, potentially limiting generalizability to GLP-1 receptor agonist naive patients. Measurement timing. Retinal images were not synchronized with the start of the tirzepatide treatment, making it difficult to determine the exact timing of progression. Population specifics. Participants had a relatively long mean diabetes duration of more than 10 years and a fairly well-optimized baseline glycemic control, which may not reflect all the patient populations. These are the references. Thank you.
Thank you so much, Dr. Tanvi. I think you have, spoken well about the whole article and you got a good grasp of it. Thank you so much. So, before we ask the panelists to comment, I think Dr. Sengupta sir is here. Uh, we will have Sengupta sir's comments on the statistical part of the article. It's a statistically heavy article, so he can just help us understand it better. And then we'll move on to the panelists. Over to you, sir.
Thanks, Zen. Can you hear me?
Sir, it's slightly soft.
Okay,
Can
just
be a
one
little
second.
louder.
Let me try. Yeah, I think you'll be able to hear me better
Yes.
now.
Yes, sir. Perfect.
Okay. So I'm actually out and I'll still hope that my video is also clear. So a few things I thought should be, discussed. Overall is, that like you finished by saying that Tanvi clearly said that the risk remains quite low. So when you look at the absolute risk, it's about 33 patients in one group and 17 in the other, right? So out of very large number of 3,000. So, so it's like 1% versus 0.5%. That's like really low, and I think when you look at even population-based studies and you look at longitudinal studies like the UKPDS and all, which follow diabetics over a long period of time, you will see that these risks pretty much mirror what others would, So do we think that only 1% diabetics will develop PDR? No, the number is still a little higher than that, So then overall, given that the number of follow-up is not very high, still it's 1%, so it's really small. And that this risk difference is like 0.6%. So it's like, if is that a higher chance? It's like, okay, 2 times higher sounds very high, but actually it's not really high in terms of the absolute number. So that's something very important. Second thing is that, only 33 versus 17 when you're comparing these numbers. So that's about 50 patients with PDR in a very large sample. So our actual sample where we are looking at this is, how are these 50 different from all these 6,000 odd? Or in the two groups, how are these 33 different from these 17? And mind you, if it was instead of 17, it became 19, that P would be not significant. And the odds ratio, 33 and 17 is like 2 times, no? So 17 into 2 is 34, right? So that 2.1%, 2.1 odds ratio pretty much comes from that. So if instead of 17, that became like 20, then that odds ratio will become like 1.30, which is like not significant because the mild NPDR numbers are like that. So this is very fragile numbers, very small numbers. So therefore, I would not really, okay, this is a trend, but this is not really sure. So it's not like a slam dunk it's like, oh, it is going to happen. It's not at all like that. And also, if you look at the lower end of the odds ratio in terms of the confidence interval, it's 1.24. That's like 24% higher chance. That's actually, again, very small. So the numbers are really small to say there is higher risk of PDR. But on the other hand, when you look at the risk of no DR or fresh onset DR, there's a protective effect that those numbers are much higher. Right? So because there are about 300 events of no DR versus any fresh DR basically happening. So those numbers, those are about 300. That's about 10% out of the whole 3,000 who got new DR. So they are large numbers, and there you can clearly see the lower risk with tirzepatide. So it's overall a protective, reassuring signal, and that is far more, significant, or let's say robust statistically, than a higher risk. I'm not saying that the risk is not high, but these numbers don't exactly, support that. Also, the study did not have any patients with 9 or 10 HbA1c. It's really not there. So baseline HbA1c is like 7.2, 7.3, something like that. Also, 84% were already on some or the other GLP-1. So this is basically switching from one to the other. So then why were these very well-controlled patients being switched? The answer is in the BMI, where it's about, it's about 31 or 32. So the difference in the two groups, that is tirzepatide and not tirzepatide, is 10 kilogram almost when you look at, when you dive into that. So then the main reason I think they are shifting is because they are all very obese. So this is a really well-controlled but obese population is what we need to understand, and not like a lean diabetic with a blood sugar of 10, which is more likely to go on tirzepatide in our settings. Also, this is an Abu Dhabi study. Though they say the London College and all, but actually, if you look at the authors, they are actually, the main data comes from Abu Dhabi. So then we don't exactly know how it differs, overall from our population. So the risk of PDR going to PDR faster is a trend. So what I would sort of take home message, especially for diabetologists, is if you're putting somebody on tirzepatide, do more. It's not like if they have moderate NPDR, don't switch them or don't start them on tirzepatide. You should definitely, because there's so many other benefits, but then they need far more screening. So we should be seeing them far more frequently. And for a retina specialist or an ophthalmologist, if we see somebody who's being switched on these drugs, we should tell them, no matter what your retinopathy status is today, we need to see you like 3 monthly for the next, say, 1.5, 2 years. I think overall these numbers which suggest that that is sort of the approach that we should take. Yeah, that's about it from me.
Thank you, sir. Dr. Sangeeta, madam, you can
Yeah.
moderate the rest.
Yeah. Thank you, Dr. Zain. I would like to invite our faculty to share their insights on this important study. Specifically, whether these findings would change your retinal screening protocols before initiating the tirzepatide.
I think we can start with Professor Dhanashree, madam. You can.
Yeah, then thank you so much. First of all, thank you for inviting me for this wonderful session. It's really a learning experience for me. And second thing is, I would like to congratulate Dr. Tanvi for an excellent presentation. She has really presented the article very lucidly and very clearly, and has given, the salient points. She has put across them very well. So very nicely done. Congratulations. Yeah. So my view on this article, I mean, leave alone the statistical part that probably Sabyasachi will be able to explain better. But first of all, the premise of the study is that whether the diabetic retinopathy is worsening with the tirzepatide or not. Now we all know that when the blood sugar is drastically controlled, you will have temporary worsening of the diabetic retinopathy. But here, all the patients are already well controlled. So there is no question of drastically reducing the blood sugar. So, how that is going to affect the diabetic retinopathy. So the basis of the study itself, I think, is a little bit not very much, justified. If there is a patient who is having a very uncontrolled sugar and HbA1c of say 10, 11 or 13, and then you have kind of controlled it drastically, then you can expect the diabetic retinopathy to worsen. But here, if you are just switching from one agent to another agent and the blood sugar is kind of maintained, then that might not affect the diabetic retinopathy much. So that is again, I feel that is one drawback of the study. And second thing is, although they have done the retinopathy wise subgroup classification, that is no retinopathy versus mild and meaning pre-existing mild to moderate and moderate to severe retinopathy. But see, we all know that this diabetic retinopathy is it's a multifactorial kind of problem. It is not just related to sugar level or even to the diabetes duration. It also varies, how much, how good the patient's control has been before the patient, was taken into the study and all. And so I feel maybe furthermore subgroup analysis could have been done based on the exact duration of the diabetes. Now they have just said that some they had about long duration about 10 years, but I mean out of these 3,500 patients, there might be some who are very long standing diabetic, some may be a little bit less diabetic. So further subgroup analysis will give you a little bit more insight into this, whether it actually worsens the diabetic retinopathy or not. And second thing is, again, the level of diabetic control. Again, they just said that it is all well controlled, but still, I think they could have done further more subgrouping based on the HbA1c to see how, how it differed from group to group. Probably that would have given you a little bit more insight, because here now it's a little bit contradictory results. On one side, they say that there is a risk of progression to PDR, high risk PDR. And then on the other side, they say that there is no risk of diabetic retinopathy, and in fact, the diabetic retinopathy is delayed. So it's, I really don't know how we can, interpret that and how we can justify that. Because if the diabetic retinopathy is getting controlled, I mean, sorry, diabetes is getting controlled drastically, then you expect the maculopathy to worsen actually, but not the PDR to worsen. Why will the PDR worsen? Because if the PDR is worsening, proliferation is occurring, that means there is some more VEGF being produced, which I mean, it's nothing to do with the, the capillaries. Like if the macular edema is getting worsening, it is because of capillary leakage, which you can understand. It's a short-term effect. When you control the sugar, that short term there can be some leakage and you can immediately have macular edema. But for the proliferation to occur, it's a long term effect. I mean, it's not going to happen immediately after you take some whatever terzepatide or whatever, because it needs the capillary non-perfusion, the ischemia has to be there for quite some time for the VEGF to be there and then for the proliferation to occur. So it's not going to be, seen immediately like the 180 days, whatever they have given 180 days duration. I doubt whether the 180 days are enough to kind of cause that kind of progression to proliferative diabetic retinopathy. So probably there is something else, also acting along with that. And like Sabyasachi mentioned, obesity is one of the factors. Then blood pressure, their kidney status, so many other factors are there which they have not, maybe they have taken into account, but they have not elaborated in the article. So we do not know whether these factors are also playing a role in this or not. So this is what I feel probably. I mean, it's good to know that it's not a very highly risky. So you can have a patient population which might be very safe, but at the same time you cannot, overlook the problems. So I feel you need to go into a little bit more depth and then analyze this paper more. Yeah, thank you.
Thank you, ma'am. Dr. Chakrabarti?
Yeah, thank you so much for having me here. And it was a really nice presentation, Dr. Tanvi. I think, the study is interesting. The current drug in question, tirzepatide, is in news for right/wrong reasons. The most important thing I thought was, they are commenting on, like Dhanashree madam just mentioned, that, on the one hand, you don't have NPDR developing, but you have more PDR. Now, the basic, fallacy in the screening was, twofold. One, they took any available photographs within 24 months prior to the initial starting of the drug, like Dr. Tanvi mentioned. And the other issue is they used a two-field photograph, which might actually not do justice to, whether these patients actually had what grade of diabetic retinopathy. Number one. Number two, the macular edema was also assessed on the basis of fundus imaging. So I think, there's a big fallacy there. So these are two very important ophthalmologically. I think these need to be pointed out. Number two, like, initially Sunny has mentioned and Madam has also mentioned that, 7.2, 7.3 HbA1c is fair control, I would say, in today's circumstances. And bringing it down to maybe 6 or 5.5 is unlikely to cause progression of DR. So actually, the DR status was missed during the study. Actually, initial part, there was not enough screening that was done. Number two, actually the study, the other point that I thought was something they should have mentioned is, like, patients who were on other GLP agonists, co-agonists or agonists, uh, whether they actually progressed, that is not indicated. I could not understand whether that is indicated. Number two, whether patients who actually had higher dose of tirzepatide, it's given between 6 and 9 was the dosage, sort of mean, sort of. But there was no, I believe, segregation of these patients into different categories to see actually what was happening. And like, statistically also, this article appeared kind of weak to me. But one very important thing that should not go out is, like, Madam and Sabyasachi mentioned, is that it is not a bad drug. So it is a good enough drug. Little bit of caution is necessary. But this, it increases PDR, is a dangerous statement that somehow comes out of the study when you read this study. So I think that is something that is very, very, very important to actually tell our physician friends. I think that is my take on the study.
Thank you, sir. May I request Dr. Borse, sir, to please enlighten.
Yeah, sure. Thank you very much, and thank you for having me. Lovely presentation. See, whenever we look at a study, we always try to see what is it for us to take as a clinical thing. Now, unfortunately, I feel that this paper offers very little to us. So, for years together, we know that any patient who is a diabetic and a very heavy diabetic, and when they have a rapid control, we have always seen that the diabetic retinopathy has increased, the maculopathy has increased. And we always say that it is basically because, yes, there is some amount of equilibrium, even if it was on the bad side with hyperglycemia that the body had got established. And then suddenly you come and destroy that, and that causes everything to go wrong. And that is what has been proposed for many years. Some of the theories have also said there's a nitric oxide pathway that comes into play, and that's why it's not development of PDR, like Dhanashree will agree, but we have seen that people who are having a rapid control, if they are already having a PDR, they come back with some amount of subhyaloid hemorrhage or something more happening from the already pre-existing blood vessels, or maculopathy increases. So this study actually doesn't give us too much of things, because where does an ophthalmologist or a retina specialist come into play? As of today, I get patients referred to me by diabetologist before starting on any GLP-1, something like that. So you are going to, the main thing from this study is that yes, you should take a fundus photograph and an OCT, but the stress point is that we have to follow this patient at least for 6 months to see whether this drug is worsening it or not. And especially if the patient is having a non-proliferative diabetic retinopathy, a high risk, even in a well-controlled diabetic, a switch of a drug can worsen it. And I think that is the only light that we can take from this. So if you have a patient who's already well controlled and they're just switching it, we cannot just casually say that, look, you're already well controlled and today you're just on NPDR, so nothing is going to happen. Something can still happen even if you're just switching a drug and even if you're in a good glycemic control. And something definitely will happen if the glycemic control is not good. So clinically, what we can take back from this is that, yes, these are great drugs to control diabetes. It will prevent onset of diabetic retinopathy by sheerly controlling the glycemia of the patient. But a patient who's already on high risk NPDR or PDR, we need to keep on following up. And that is the message that we need to give it off to our fellow diabetologists, that look, you sent it to me today, but please send them to me again after 2 months and again after 2 months and again after 2 months, so that we can actually document whether it is worsening or not. I think that's what we should do.
Thank you, sir. Thank you. I would like if any comments or experiences from the faculty would be greatly appreciated. Um, Dr. Dhanashri ma'am, Dr. Chakravarti sir, any comments or experiences regarding patients?
So actually, I have one patient who I was following, and somehow the patient also lives for some time. He lives in France, and sometime he lives in India. So whenever he was in France, he was being treated with this one, not Monjaro, the other one. What is the other drug?
Ozempic.
Ozempic. Yes, Ozempic. So he was on Ozempic and he was getting this Ozempic. He was also very obese, and so he was getting Ozempic. And he already had a PDR, and the laser was all done. PRP was done multiple times. It was well lasered, but still, patient progressed to vitreous hemorrhage, and patient one day suddenly came with a worsening of TRD. I mean, it was a little bit dramatic worsening. So I think he had received this Ozempic on one of his trips, and then when he came to India, there was a sudden worsening of this TRD. He had developed TRD, and he had developed also some breaks and retinal detachment, vitreous hemorrhage. So he had to have surgery also immediately. So that is one patient I know that who got worsened because of Ozempic.
Oh,
So actually, in studies, Ozempic has showed in sustain. I mean, there is a big. If you see the studies of Ozempic versus
Yeah.
Mounjaro, the Ozempic arm has actually shown a lot of red flags about retinopathy vis-a-vis the Mounjaro. They have not really done a great thing of ophthal thing. But in a sustain 6, you will see there is a good amount of documentation of worsening of PDR, vitreous hemorrhage, exactly like what Dhanashri has said. So maybe as compared to Mounjaro, Ozempic definitely has got a maybe from the studies that there is a more effect of worsening of diabetic retinopathy. Yeah.
so
I
whether
would
yes,
I would
yes.
like to ask Chakravarti sir, sir, what do you feel that this finding that has come out from this study that the PDR, there's a risk to progression of PDR. Is this a statistical aberration or is this something that could be expected?
I think a very interesting question. Part of it, I think already Sabyasachi has answered, and I strongly believe, out of 3,000 odd patients, if you have, figures in the range of 19 and 30, you are looking at something uh, very minuscule. Number one. Number two is, the basic screening was, I think, faulty, and these were things that actually the initially were before publication the reviewers should have pointed out to the authors so that they could have uh, provided us with those in bits of information which would have really made it very interesting. So that is one. The other thing is, I have had experience with physicians actually not understanding before prescribing these GLP agonist drugs uh, regarding the necessity of frequent intervals of frequent screenings. So I think of the retina, that is. So I think this is something. This is a very important thing. Especially with Ozempic. Of course, with this drug also it might be the case. I'm not sure what long term we will be seeing. So actually, we need to be on the guard with these drugs to some extent, and actually the screening has to be proper. So that is what was lacking in the study. It was not properly screened. I think the retina part was not nicely done. And this is something that actually the physicians have to be told, because these drugs are increasingly catching the attention of the physicians slash diabetologists, endocrinologists. And this is something that I think is very important.
Sir, I would like to ask whether these findings would change our retinal screening protocols before starting the therapy.
I think, if you have these drugs being started, initial baseline retinal examination is necessary. And like Nishikant sir has already mentioned, 3 monthly post starting, 3 monthly, at least 3 monthly examinations, I think, are in order, given the propensity of these drugs to be used in relatively obese individuals. That's what I have seen the physicians mostly do. And also because, there could be a sharp, decline in the HbA1c levels or the diabetic status. So I think, this is something that's very important.
Okay, thank you, sir.
Borse sir, I would like to ask you, let us say that a physician has referred to you a patient for screening. They want to start, and you see the patient has moderate or severe NPDR first time detected. Okay, now does this become an indication for you to tell the physician don't start this, or is only screening required?
I think it's only going to be screening. Look, why the physician wants to start this drug is basically because the basic drugs have not really worked for that patient, number one, or if the patient is going to be obese. Whichever way, these are risk factors for progression. So, the best bet is you have a good glycemic control. But I would definitely like to stress that I would like to see this patient again as soon as you complete at least 2 or 3 months, because we have to keep a tab on the diabetic retinopathy part. Yeah. So it cannot be a contraindication to start. I mean, I think it's as simple as that.
Do you stratify your screening protocol according to the degree of retinopathy, or irrespective of the degree of retinopathy?
No, as per the degree, definitely. Now, if you are having already got a severe amount of PDR and you're treating it, then obviously you're going to see them much more often. Now, you see a patient having a very mild NPDR, no maculopathy, nothing, then you are okay. You are very liberal with that. Nothing is going to go wrong in a short term. And like Dhanashree said, PDR is not going to develop within 6 months, whatever you do. So it's basically you can be liberal as per the retinopathy itself.
Zen, I have a question for any of the faculties that in case you see progression of the retinopathy, especially PDR after starting the drug in a clinical scenario, what do you do then? Do you change the drug? Do you increase? How does that change your treatment protocol, and what would you advise the physician accordingly then?
So I think this particular study has shown that even if you switch, you can get a progression. So this study, if you actually take it seriously, it shows that it doesn't leave the physician much choice of uh, changing the drug. The only thing left is for the ophthalmologist to be more aggressive in the treatment, because even if you're going to switch, you're going to get a progression. So that's it.
Would you stop the GLP-1 altogether and shift to other methods then, or you would just increase your ophthalmic treatment, whether it's laser, whether it's anti-VEGF, whatever is required?
So if the patient has already got a good glycemic control and they have stabilized the patient well, and the progression has already occurred, now stopping it might actually worsen the hyperglycemia and might worsen it further. So just let's go ahead with that's what I feel. We can go ahead with a more aggressive treatment of the retinopathy and let them control the hyperglycemia. The main thing is to pick it up early and treat it aggressively.
Borse sir, then would the further prospective studies will help it out
Quite a
with
bit.
regular follow-ups and regular retinal examinations? Will it
Yeah.
help us?
There is a lot for us to learn about these drugs. So many a times what happens is when a drug comes in, we start believing that these particular things are happening because of the drug. Now, whether it was basically because of the drug or not because of the drug or just a strong hyperglycemic control, all that will come over a period of time. So, like we have been practicing for a long time, and when some different insulins came in, like Lantus and all. Again, there was a lot of anxiety whether these drugs are causing an increased PDR and all. And over a period of time, we sort of settled off and said that no, this is just a natural progression of the diabetic retinopathy. So yes, a lot of studies are needed and a lot of experience is needed for us. So we really don't know how it is going to fan out over a period of time. So only that will come to know. Yeah.
Yes, sir.
So I just want to ask all the panelists, uh, what is the opinion of the physicians with respect to the eye and this drug? Is there any role at all of showing a ophthalmologist or a retina specialist on starting this drug, or is there, because that is the impression I am getting, that there is no correlation of screening the retina when you are starting this drug. It's just a normal retinopathy screening that you do for all diabetics. So is there any role at all of the retina specialist? Dhanashree madam, if you could answer.
Yes, and this is a very relevant question because it is very imperative that the physician knows that they have to screen the patient for retinopathy before they start this drug, because that is exactly what happened in the Sustain 6 trial. The patients were not screened, and then they suddenly came with vitreous hemorrhage, and in fact the study had to be stopped. So in midway, so that is the reason. So patient should be made aware, and also the physician should be aware that there is a possibility of the diabetic retinopathy worsening, and patient may land up with vitreous hemorrhage and lost vision, etc. So it is good to do baseline retinopathy screening and to see what is the grade of the retinopathy at baseline. In case it is a PDR or a very severe NPDR, then preferably they may have to reassess their call about putting this patient on this GLP-1 agonist, or maybe they can think of something else, because there is a risk of progression and landing the patient with vitreous hemorrhage and all. In case the retinopathy is mild or no retinopathy, then it is safe. Then probably they can go on. But even then, what I feel is that these GLP-1 agonists and all, they are reducing the blood sugar level and all, but actually the basic, micropathology which occurs in diabetes, that microvascular occlusion and all that, that is not being addressed by the medicines. That is, I think, continues, despite the, blood sugar control and all. So that is why you see this retinopathy progression. So that doesn't mean that even if your blood sugar is under control, you need to have eye screening regularly.
Madam, but this would work for any change of drug, right? It is not specific to this class of drugs.
Yeah, I agree. But right now, because it's a new drug, and it is so effective, and it is also causing the weight loss. So I think they're becoming more popular as weight loss drug rather than diabetic drugs. So no, but because of this, the sudden popularity of the drugs, it is being used by one and all. So that's why more caution is needed. Otherwise, insulin also will cause, but nobody is just simply, injecting insulin just like that. So they are careful about that. Similar care has to be taken for these drugs also.
Okay.
Dhanashree, have you seen any case of AION with any of these drugs? Because I have seen one patient who was put on this drug and within 2 weeks had AION. So I really don't know. I mean, I could not give an answer whether it was due to the drug or it was just event of diabetic patient. Any experience there, Dulal or Dhanashree?
I have not seen any patient for AION.
AION, yeah.
Yeah, but
Yeah, I've seen a couple with Ozempic, and again, like you, I couldn't actually tell the physician to stop the drug. But I was happy that the control was relatively better.
you see,
From somewhere around 10, the patients had come down to probably one was around 7.8, the other one was probably 7.6. So I think, but it was a very short period. It was the between the two HbA1cs, it was a gap of only 2 months. So, that is something that was, a point of concern. So, diabetic control is good for all, but the number two thing is, something that's very important should be realized is that quick control of diabetes, unless absolutely indicated for some other reason, might, cause worsening of other issues of the patient.
Definitely.
Sir, you are on mute, Vaishal sir.
Yeah. So I think we had a great discussion today, and it shows that patients, when irrespective of the drug, they should be screened more closely. And it was a great insightful that when these new drugs come in, we have to look in the diabetic retinopathy, because the pathology is not being controlled by these drugs. So definitely, it was a great discussion and very insightful. And I would like to conclude the meeting and ask Dr. Neeraj Israni to give a vote of thanks.
Thank you so much, Dr. Vaishal. Firstly, I would like to thank the pillar of this journal club, that is Dr. Vaishal Kenya. I think continuing the journal club for almost 3 years now and finding such trendy yet interesting topics which are out of the box. So, thank you so much, sir, for continuing this. Uh, Dr. Maya Modawala, thank you for being part of this journal club as usual since the last. He's the secretary of BOA and he's a dynamic secretary. Thank you for being there. Our panelists and moderator, I'll start with the moderator, Dr. Sangeeta, who has moderated the session along with Dr. Zain Khatib. Thank you, madam, for being part. Unfortunately, Dr. Archana is traveling. So, madam, thanks for being part of this journal club. And thanks to Tanvi, who was our postgraduate, who made sure that everybody just, she just presented the study in a way that everybody could actually grasp the important points out of the study. Our panelists, that is Dr. Chakravarti, Dr. Nishikant Borse, and Dr. Dhanashri, thank you for taking out such important time and interesting for this interesting meet and an interesting topic. And we are grateful to you for all the important insights that you've given us. Lastly, I would like to thank the Entod support team for making sure that this journal club runs smoothly. Sunil ji, thank you for making sure that the recording is done and it is posted on YouTube. I encourage everybody to keep attending the journal club meetings. And over to you, sir. If I missed anybody, please let me know. I think.
I would personally want to thank Dhanashri madam, Dr. Chakrabarti, and Dr. Borse for sparing their time and coming and sharing their insights on this great topic. And thank you, Sangeeta madam and Tanvi. That was a
Thank
great
you, sir.
presentation from your side. And
Thank you, sir.
I would encourage the audience to participate in big numbers, especially the postgraduates, because this program is intended for them and the general ophthalmologist. So this program is also posted on the YouTube and the Facebook. So if someone has missed, you can definitely ask them to watch it there. Thank you, everyone. Thank you so much.
Thank
Meet
you.
you again
Thank
for
you
the
very much.
next
Thank you.
Great
Journal
meeting
Club
you.
Thank you
meeting.
so
Thank
much.
you.
Thank you.